谢谢大家。
All right. Thank you, Dr. Neuhann, for this amazing speech and for this amazing technology. Actually, and I'd like to thank Dr. Chen too for the wonderful interpretation. 谢谢. Yeah, I have some questions for Dr. Neuhann. And for clinicians, many clinicians are the major concerns for their clinical practice is how to achieve the optimal vault. So sizing is always a hot topic among ICL surgeons. So what's your technique? Current technique for your sizing? Do you consider sulcus to sulcus or angle to angle in addition to wide or something? What's your secret weapon for sizing?
We have no secret weapons because sometimes we have also high vault and have to change it. It's rare. The most safest part is in, let's say, 98% wide to wide. Wide to wide corresponds not too bad, but we have also pitfalls. And therefore, we take angle to angle with the same measurement. And we take also in account the configuration of the angle. And interesting is when we look through our data that in the, let's say in the years between 2000 2010, we had the majority of 13.2 length of the ICL. And when the production changed from Switzerland to United States, the diameter which we use today is 12.6. There was also a little production difference. Why? I don't know. But the three things, wide to wide, angle to angle, and angle configuration, is that what we take in account?
Mm-hmm. What do you think is the ideal vault? Dr. Shimizu said he thinks it's no longer 500 microns. Instead, he thinks 250 is the optimal or ideal vault. What do you think?
Yeah, it's 250 is super, but the 250 distance won't stay forever. The gracillins grows. Mm-hmm. And what we see, and also in my vault data for Asian and Japan vault, we saw if you have 500 vault postoperatively, which is good if the angle is okay, mm-hmm. This vault will shrink over the time and go to 200, 250, and 100. Mm-hmm. So that vault, what you measure postoperatively, won't stay forever. And therefore, I agree with Jimmy would say 250 is ideally super. But if we have 500 or even if we have 700 and the angle is great, we leave it. So there is a wide variation of distances which are okay. Because pigment dispersion, what many colleagues who don't implant ICLs know it better, that there is a pigment dispersion, but we have no pigment dispersion syndrome since 30 years. So 250 is great, but if it is 700, 600, 500, I don't care if the angle is okay.
I cannot agree more with you when about the angle configuration is very important. So high volt sometimes is more problematic compared to low volt. So what do you think is the how do you consider if the angle is normal or dangerous if we have a high volt patient?
The amazing thing is, even if you have 1,000 or 1,200 distance, the patient sees good. If the angle is too small, because STAR recommends to implant the lens horizontally from 0 to 180 degrees. If your vault is too high, then I really would recommend to turn it for 90 degrees if it is a spherical lens, because the sulcus is not geometrically round. It's not oval. It's has whatever. So rotation of the ICL will solve in many problems high vault problem. And as you showed in here in the slides, we had a toric ICL with a high vault. The OCT showed us, hey, the ICL sits not in the sulcus. This can happen. Why? We can discuss it for hours, why the ICL didn't sit in the sulcus. So just rotation in the toric lens in 180 degrees solved this problem. This was a patient with Japanese root. So his sister, from this sample which I showed, had quite the same problem. But we knew it, and intraoperatively, we could solve it immediately when we realized it has also a high vault. Sometimes there is something behind the iris. We don't know it, we don't see it, but we can realize. And sometimes rotation of the ICL with a HPMC injection, you can rotate the ICL without harming the crystalline lens.
Mm-hmm. So if you have a patient with a high volt, say 1,000 microns, and a very shallow angle, but the IOP is normal, do you, explant or exchange the IOL, or just?
As long as the patient has a good tension and has a good vision, I inform the patient. I tell him that his angle is small, and it could happen that his IOP will raise also suddenly. So I think the best way is to inform the patient what we see, and because we have the problem with the high vault, not the patient. And what I saw, I have had several patients in the past 30 years with a very high vault. And where I looked inside the wall, I inform the patient, I tell him if he has no pain and his vision is good, we leave it. We are not in a hurry. I ask him to come after 3 months. We take endothelial cell count and we take pressure. And we measure the distance. And what we always see, is that the distance goes down.
So this brings me to the other question, is the opposite. How about how to deal with the extremely low vault? Say nearly a 0 vault. Do you observe or do you exchange or explant it?
Both. What I have seen in the last 30 years is ICL with low diopters, let's say -5, maximum -6. If the ICL has a diopter -2, -3, -4, -5, and has no vault, I leave it, as long as it has a central hole. because what I have seen is that small ICLs, even from the time where we had no central flow, they don't get any cataract. If you have -5, -6, -7 or so, and no walt, I will exchange.
Okay, great. And do you take the age into consideration when you make a decision?
Yes, if it is a patient with 40, 45.
If the patient is young, for example, 24.
100%. I 100% leave it if it has -5 and has no distance. And if its visual acuity is great, sits on the lens, has a central hole, because every of us knows that water will always find holes and go through. And what I showed is that lens metabolism in the early phase of the ICL was disturbed. But even in these early cases with low diopters, sitting on the lens, young patient, no cataract.
Great. And do you think UBM is useful for the pre-op assessment? Do you do it?
Yes,
routinely?
It is. It's UBM is one information more, but it's so difficult because you don't measure exactly that point where the foot plates will be there, and because it's not a geometric area, our sulcus. You can measure with the UBM. I like to do it. If I have somebody who is doing it, because it always takes 15, 20 minutes, even if he's skillful. But when we find cysts, and we find it sometimes, this is helpful, because then we calculate from 12 o'clock to 6 o'clock. So UBM is helpful, but it's expensive, time-consuming, and
it's not
when we see that 85% of the world does not use the UBM, and we have these results which I showed, it's hard to argue for the UBM. All
right. When it comes to the indications for ICL, what is your cutoff? How many percent of your patients are ICL, and how many percent are laser vision correction?
Yeah.
And what is the point? Yeah,
you asked the wrong doctor, because I started with ICL, so I gave my wife ICL, and I'm married with the ICL. So this is my problem. I love it because of the excellent visual acuity. We have 50% of ICL patients, and the rest is 40% is trans-BRK and 10% is LASIK. And I have now my son in the office, and he wants to start SMILE because we have now the second generation of the laser available. And I think now it's a good time to start for SMILE for the low diopters. And not every patient wants to have a ICL.
All right, and you're the ICL manipulator is very. I mean, yeah, it's very interesting, and you're very smart in inventing new things like the hand electrifying and this new manipulator. Do you use your manipulator routinely, or you use it just needed?
Sorry, I didn't understand.
I mean, do you use your manipulator you showed us in the video
in every case
routinely, or
in every case?
Just it.
Sometimes sometimes it's not necessary, because the pupil is so wide that You inject the lens on in the distance, it's already under the iris, and with the spatula, it's easy to go. So I have it in hand. Often I use it. Sometimes I don't use it. So it's good to have, but it's not a must use. It's just if I see pupil is too small or it's difficult to go underneath, I like to use the second hand.
Yeah, I have a question from the audience. And do you check the thickness of the crystal lens? If the patient is a very thick lens, for example, 4.6 millimeters thick, do you implant ICL on this patient?
If the anterior chamber and the angle configuration is good, yes, why not?
Mm-hmm. Okay. And actually, we have a lot of questions to ask you. Do we still have time?
Yes. It's carnival outside.
You can have 15 minutes more.
Okay, thank you. So actually, I have a personal question. I have a very complicated case myself recently. The patient is a steroid responder, and he told me that he got elevated IOP. Even he took a steroid pill, only one pill. So and he is a high myopic, minus 17 or something. And I implanted ICL in both eyes, and the surgery was uneventful, and the vault is now 260, ideal for him because his AC is only 2.8. However, and I didn't use any steroid because he's a steroid responder, but he continued to have high IOP, and his angle is wide, and the vault is low, maybe I should say ideal for him. The question I like to ask you is, what is the mechanism? What is the possible mechanism for this high IOP after surgery? This is now this is about 1 week after surgery, and what can I do?
I have no crystal ball to see it really. But we know that about 30% of myopic patients have glaucoma, and the surgery could be a induction that he develops his normal wide-angle glaucoma. In these cases, we have seen this also. I start with a low myotic drop, which is 1% of pilocarpine. If pilocarpine works, then because they get pain with 1% pilocarpine sometimes. But if pilocarpine 1% works 3 times a day, then it's the angle. If you use, for example, a fluoroquinolone, a prostaglandin, taflotan, for that, and he will react, then it's his normal myopic glaucoma. And if he won't take drops, in these cases, we just recently did that, but the patient, after 15 years of ICL, I implanted the hydrous stent. Really magic. 12 from 34, wide-angle glaucoma, not tolerant to any drops. So after 1 week, what your patient has just start with the drops, perhaps with pills. You are not in hurry. You're absolutely not in hurry. And ICL is not really inducing glaucoma. It's high myopic, and the glaucoma which he perhaps want to develop, the surgery is the reason. He is sensitive. Typical high myopic patients are often steroid responders, and therefore I would try with pilocarpine and take time. The patient and you need a little bit time, then you will see you gain time, and it will become good.
Thank you for the advice. What makes this patient more complicated is that this patient is also with high cylinder, minus 3.5 in both eyes. And unfortunately, both toric eye cells rotated 90 degrees. Oh.
Bingo. Okay, bad luck.
Bad luck, yeah.
So if the rotation, and you do a re-rotation, then they will rotate again. They will rotate again, 100%. Because if they once rotate like this, they will rotate again. Then we have two options. Let's say the not so good option is leave the ICL where it is. Look when it is stable, and then you do accurate incisions with the femto, which is not so good. I would explant the lens and take a toric artisan lens. If the chamber is deep
toric artisan is not available in China. It's not approved.
I had that. I had the rotation 13.7 from a colleague, both eyes, 13.7 sizing, high cylinder rotation. He did rotated back, re-rotated. I took it out and took a toric artisan lens, perfect results. You don't have it? Then I think, look if the position of the toric ICL now is quite stable. If it is stable, arcuate incisions, but they are long. Because you double the, no.
Okay, thank you.
It's not a good solution.
So let me see if there's any more questions from the audience.
I have a question.
Yeah, we have time for 2 questions.
Yeah. Yeah. Since our topic today is about the long-term safety, about the ICL, right? So
靠着屏幕，你又断断续续了。
对，听不太清楚。
Sorry, I will speak it again. Since our topic today is about the long-term safety of the ICL, there is a question keeping wondering in my mind is that, as we know, the foot plates is not right in the sulcus. It's happened right in this situation. Do you concerns about that if the foot place keep always behind the ciliary body and it may touch the sensory ligament? Can it do some harm to the
Zonials?
zonule? And
yeah, sure.
In the long
term, what you have seen in the beginning, there was from Roberto Saldivar, the ICL with the hole from 1994. And this ICL was decentered. This was surgical learning curve. We decentered it too much. And you can, if you decenter the lens too far, you crack the crystalline, the cellulose. And there are reports from the early phases that ICLs were seen in the
vitreous.
Yeah.
Yeah.
Much more how you call it, the other phakic lens,
The PRL. Yeah.
The PRL was
Yeah.
much often seen, but it's the same mechanism. If you decenter it too far, then you will crack the zonulas. And this is the reason why I invented this modified Sinskey hook, because with the Sinskey hook you can decenter and also not too much. And if you decentered with the Sinskey, the ICL goes into the anterior chamber. It folds into your chamber and not goes peripheral. And therefore, if you use two instruments, much easier than if you have one instrument, because with the one instrument, you have to decenter it far to get under the iris.
Great. And another concern for me is that when you do this bimanual technique, use your Sinskey, and the patient has to be very cooperative. If the patient is nervous, the eye moves a lot, that could be dangerous, isn't it?
Absolutely contrary.
No. On the contrary?
Yeah. Why? Because you're Chinese. Japanese has sticks to eat, but in China, I think you have also. If you have two sticks in the eye, the patient can do what he wants. You control the movement of the eye.
Okay. All right.
If you have one instrument, difficult. Patient looks around, and if you have two instruments, you guide the globe where you want to have it. You have it.
So, if I have a chance, I like to try.
It's easy. It's simple. And the opening, the paracentesis, is very small, much smaller than the side port from phaco incisions. It's much smaller.
Great. 还有其他问题吗？
小贝医生，您能把这个问题的中文问题和讲解都翻译一下给在线的听众们吗？
我们是不是要在结束的时候才那个呀？
可以，行。
现在就开始。
我们应该还有一个问题。
还有一个问题在这儿吗？哎，没看到。
我发给小贝医生了。
问了，王院都问了。
两个问题都问了。好的，那就请王院您来做一个总结吧。
好吧，刚才就是 Dr. Neuhann 给我们讲了非常详细的一个历史啊，有些东西我们可能都不知道，对吧？我们之前可能像那种用手工打孔的这个，我还是第一次看到啊，这个也是体现出我们的这些学者们他们的这种创造的精神哈，我觉得还是非常值得我们学习的。那么也看到的话呢，就是我们这个 ICL 经过这么长时间的不断的演进，以及很多科学的这些数据的验证吧，就是说它的长期的安全性还是非常好的。那么我们问的问题呢，哎呀，我有些可能都不太记得了啊。我当然一个呢，就是我们可能最关心的就是我们的这个尺寸的把握。那么主要是考虑什么东西什么是个理想的汞高啊？因为像清水教授呢，他的我就问他这个理想的汞高，因为清水教授说是250，他觉得500太高了啊，250就是一个很好的一个汞高。那他也同意，就是当然呢，这个因为我们都知道，随着时间的这汞高是会往下降的，所以一开始250可能还是偏低了，那最终是一个250的话呢，可能还是个非常好的一个汞高。那么还有一个，哎呀，我都问了些啥问题？待会儿那个小贝你提醒我一下啊，我这边有些啥问题呢？哦，对，他在刚才讨论当中呢，很多强调的就是这个防角的一个形态。那么我也问到了很多，就是像高汞高啊、低汞高啊这些处理。那么高汞高啊，那对于牛远教授呢，就是讲到呢，他如果是防角的这个结构基本上是正常，然后这个眼压也是正常，视力也是正常的话呢，他觉得因为 这个汞高慢慢会往下降嘛，所以他觉得观察就可以了。所以尽管有些比较高的，那么这些正常的话，它还是可以观察的。那么低汞高的话呢，那么就是如果是一个低度近视，那么他觉得就算是零汞高，发生白内障的机会几乎等于零啊。那他说就是像这种200-300度、300-500度的这种，那么就算是零汞高，20多岁啊，这种呢，他可能也不，他觉得也不用管啊，不用去理他啊。那么从他过去的这么多年的历史来看的话呢，发生白内障的机会几乎是零啊，所以这个是不需要去动他的。那么我也问他呢，就是在他的病人里边啊，那 ICL 的占比有多少啊？那么他说我问错人了，因为他自己是比较倾向于 ICL 的啊，因为他他很早就开始做 ICL 啊。那么刚才那个视频里边看到的那个就是手工钻孔的那个是给他太太做的。那么多年前他就给他太太做了，所以就他对 ICL 是一直是比较喜欢的啊，所以他的意思就是说他可能有一些倾向性吧。那么在他的病人里边是占了50%啊，这个 ICL， 当然这个我们可以作为一个参考了。再就是还有什么呢？我就问了我的自己的一个病人啊，最近上个礼拜的病人啊，我觉得也挺头疼啊，就是这个病人一个超高度的啊，1700度，然后又有350度的散光，两只眼都这样。那么这个病人的本身他就是对激素敏感，他自己也知道，吃一粒眼压就高，口服一粒这个激素眼压都会高的。那么我们做手术就很顺利，现在汞高呢也是260啊，对于他来讲很好啊。那么我们术后也没有用任何的激素，但是他手术以后立马眼睛这个眼压就高了啊。那么我现在也搞不清楚这个原因到底在哪啊，因为房角现在看的还是开的，还是很宽的啊，然后我们也没用激素啊，但是他眼压就是那么高，那么怎么去处理啊？那Neuhann教授呢，他觉得啊，当然这个很少见啊，那么他的这个想法呢，也是就是我觉得还是很好的。那么就是我们要考虑一个呢，就是高度近视，像这种特别是这种超高度近视，其实青光眼是很常见的。啊，那么我们就要搞清楚它是开角性青光眼还是闭角性青光眼啊。那么他建议呢，就是从1%的皮洛卡品开始给他 BID 的点，如果点了这个皮洛卡品，那个眼压就降下来了，那么说明这个还是可能是跟房角有关系啊。也就是说，尽管我们这现在房角还是很宽，但是因为我们放了这个 ICL， 它多多少少还是变窄了一点啊。那么这个还是有影响。那么如果是没有啊，就是你缩瞳还是不下来啊，那反而是用像这种贝塔就是 Timolol 啊这一类的，能够降下来的话呢，就考虑可能是这种高度近视这样的这个加上这个慢性开角性青光眼啊，就是从这个考虑。那么这个病人呢，又更加不幸的呢，就是他那么高的散光啊，但是他做完以后两只眼莫名其妙就突然转了差不多90度啊，所以现在变成了600度、700度的散光啊，那怎么处理啊？那么这里当然Neuhann教授跟我们谈到的这些想法，跟我们平时讨论的很相似了啊。那当然就是换晶体啊什么乱七八糟，这个我就不重复了啊，这个就没有什么太多那个还有啥？
刚好是有个人问。刚好这个旋转的处理，有人问这个问题，所以你还是讲一讲怎么。
那我还是要讲一讲。OK，
对，
那旋转呢？那么像这么大幅度的旋转，那么其实就是意味着我们的眼睛里边的结构呢，这个就是睫状沟的形态，它不是圆的，它是一个竖的椭圆，然后呢，这个晶体就会往这边转。那么我们给它调位的意义其实是不大的，因为调位以后，它重新再转回来的机会是非常高的。所以处理的话呢，就是可能考虑一个在角膜上面去解决散光了啊。那么这是一个问题。那么还有一个问题，刚才Neuhann教授没有提到的，但是我们以前也有用过成功的，那就是当它这个如果是观察一段时间，它的这个晶体的轴向是真的是稳定在那个地方的话呢，那我们就按照那个位置去定做一个带散光的 toric 晶体啊，那么也可以解决问题 那么除此之外呢，就是我们可以把它换成非散光的晶体，然后在角膜上面做散光啊，可以做这个松解切开，也可以做激光啊。那么更懒的方法呢，就是我们现在这个晶体就不动它了啊，那等它稳定下来，现在不是600度散光吗？啊，那么就在角膜上面做600度。当然，他刚才Neuhann教授也说了，这个是不是很好的一个方法？当然，这个是最懒的、最懒的方法吧？啊，大概是这样。
哎，那个中国没有出现的晶体是什么？它是
那个是 Addison， 就是一个前房型的啊，那个是没有的，我们现在没有，不用考虑了，就是那种虹膜加持的。
那还有您问了一个晶体厚度的问题，
对。那个对，这个是有一位同道问的啊，就是这个晶体都很厚，比如说4.6，那能不能做 ICL 呢？那么Neuhann教授的意思就是说，如果它的这个房角的结构正常，前房深度也正常，它是可以做的。就是说他意思就是说这个它不是它的一个禁忌。
然后就是我自己问的一个问题，我其实问的就是说。假如我们知道有一些晶体的绞盘不会就刚好在这个睫状沟内然后长期来讲，它如果就是在悬韧带方面会不会引起一些危害？那么Dr. Neuhann 的意思就是说，其实这个肯定还是要想到有这样的危害性的，包括我们在之前的这个在课上也有看到有那样的图片，就是偏中心，就是那个晶体往下沉的这种状态，肯定跟这个悬韧带的这个关系是非常大的，要考虑。还有就是包括他提到他用的这个用的手术中刚刚他发明的这个调位器哈，就是这个，其实他说用它来操作的话，可以减轻对悬韧带的这个压力，就所以也提醒我们没有这种器械的时候，我们在做一些操作术中的操作的时候要注意，就是要太过多的偏位，然后压到对侧的这个调攀的过程压到对侧的悬韧带，对悬韧带造成一定的损害。
对，讲到这个悬韧带的损害呢，那么Neuhann教授也提到过，在早期呢是有这样的一些病例的报告的，就是说我们在这个学习曲线上面，就是这个偏位偏得太厉害，对侧的悬韧带压迫得很厉害，就给它压断了，然后呢，这个晶体就掉到玻璃体腔里去了啊。ICL 呢其实也发生过的啊，那么这些就跟操作可能关系比较大一些了。那么另外一种晶体啊，那么刚才Neuhann教授也提到的，就是这个 PRL 晶体啊，那么这个在国内现在有些地方在做啊，那么这个呢，它的就是最大的不好的地方就是它这个掉到玻璃体腔里边的机会比 ICL 要大很多，而且的话呢，它不光是在手术操作这个时候会掉，那么你植进去以后，它在里面飘着的这个时间。就是也是会对悬韧带有一些损伤，所以也会有掉到里边去，所以这个也是为什么我们现在暂时还不太考虑做这个手术的一个重要的原因。